Hi, everyone. I'm Dale Branda with Stewart Advisors. Welcome to today's webinar, where we're going to be taking a deep dive into healthcare insurance and how it affects your financial plan. So before we get started, let me introduce our speakers for today. Monica Kendall is a highly successful, knowledgeable independent insurance consultant for Healthcare Solutions team. Her mission is to remove the confusion and the uncertainty around choosing the right health insurance for her clients and their families. She's a really valuable resource, and she advocates for clients well beyond just choosing a policy. Our other presenter today is Mike Kwan, who's a principal with Stewart Advisors. Mike's a comprehensive financial planner and an investment advisor who works on a fee-only basis. He helps bring clarity to his clients' personal finances and gives them peace of mind, knowing that they're addressing complex issues with wise, thoughtful choices. Mike's interests always align with those of his clients. Mike and Monica are well acquainted. They're part of a membership group of business advisors that Mike co-founded called the Trusted Advisors Council. So our format today is going to be a guided discussion. So let me turn things over to Mike and Monica and we'll get started.
Welcome everyone to our Ask an Expert webinar. When it comes to finding the best and right health coverages, it can be easy to make mistakes because the nuances of insurance and coverages are complex and changing. These misunderstandings can lead to frustration in getting through the claims process and can cost thousands of dollars in bill payment issues. People really need a healthcare advocate to help them sort through the complex issues, like Monica. The healthcare exchange is not enough. You've seen your clients become seriously ill with a heart attack or had a difficult cancer diagnosis. Monica, can you share how much one of these illnesses costs and some issues your clients have had to deal with?
I've had a lot of large claim issues with some of my clients, and you know, a heart attack could easily be half $500,000 in medical bills. That's what your insurance is for. And one of the biggest things I always like to tell people is to remember that why you buy the insurance. Sometimes people get down in the weeds looking at different plans and go, well, this one's a $15 copay for a doctor's visit, and this one's a $10 copay for a doctor's visit. You know, that's really not why you buy it. Those are details. You buy it to protect your money, the money that you've saved and earned and hopefully well invested with somebody like Mike. You save, it's the kind of thing that can be devastating to somebody. So the things to watch for are the maximum out-of-pocket number on a plan, okay? So I hear people say to me quite often, oh my gosh, an $8,500 out-of-pocket maximum, what's the point of having the insurance? I'm not gonna do that, I'll just take my chances. You know, some insurance is better than none, whatever you can afford, because if you're looking at $500,000 worth of bills, suddenly that $8,500 is going to be a pretty reasonable amount that you're going to be happy that you had it. Also, people forget that you're getting network discounts, and that can knock all of the bills down to half or less with the negotiated rates. So choose a plan, you know, based on what your financial risk can handle. You know, it needs to be the most important thing that you think about there. Also, I've seen people who get really snowballed into the whole medical billing mess. It's a mess, there's no doubt. I mean, there's always more and more bills coming at you, and it starts to become overwhelming. You need to wait until your explanation of benefits or EOBs come back from your insurance, and they tie up and match what the bill shows, and then you're ready to pay it. If you don't see those EOBs coming in a timely fashion, and you don't see those bills being adjusted down in a timely fashion, reach out. If you start to see the notice from the medical provider that says you're past your 90 days, this is going to be handed to collections, then you need to reach out to the provider and go, what's going on? I see it's still pending through my insurance. Please give me another 90 days. We need to find out why it's not coming through the insurance. Then reach out to your insurance and call them up about a particular claim and say, why isn't this processed yet? And they might say that they've been asking for more information on it, like a code is wrong or something like that. So you have to be your own best advocate. But I will tell you, if you pay that medical bill too fast, once they get your money, because you probably would be overpaying if that were the case, once they get your money, it's really hard to get your money back. So you don't want to do that. Insurance is a contract. Not everything is covered. You need to know that the basic idea between what your insurance will cover and what it doesn't is medical necessity. So, if you're just going for some, a nip and tuck on your chin, that's not going to be a medical necessity. So that's an important thing. So you need to kind of be aware of the general ideas there.
Thanks, Monica, for helping to help people to understand some of the potential pitfalls and how to protect yourself and just put yourself in a better position to kind of get yourself through these difficult situations should they occur. The Affordable Care Act is one choice for individual insurance. Plans without government subsidies have become expensive. For those willing to take a $20,000 or $25,000 out-of-pocket risk, other alternatives have become available to save thousands of premium dollars. And maybe you can help our audience to understand some of the choices within the individual healthcare market.
Sure. Basically, there's what I like to call the two basic buckets: Obamacare and non-Obamacare. And the biggest difference between the two is through the marketplace. You can, if you qualify for a subsidy, if your income's lower, you can, it could be very reasonable to go through that way, and you wouldn't want to look at a non-Obamacare option. But the Obamacare options are about twice as expensive as the non-Obamacare options. But the biggest difference is that they are, like this chart shows, the non-Obamacare options will not have coverage for pre-existing conditions, mental health services, or maternity. It will cover your preventative wellness, but it won't necessarily cover that for free. So those are the big things that are different between the two. The other thing is, on an Obamacare plan, you can only get it during open enrollment or if you have a special enrollment period, okay? So special enrollment might be that you lost your coverage through work or something like that. And then you can get it outside of the open enrollment. We're in open enrollment right now. And that goes from November 1st through December 15th to get a January 1st effective date on a new plan. That's the only time you can make changes to your plan. You can always get into your plan if you have a change in income. So you could always change the income and the subsidy levels during the year, but you can't change the plan. So it's an important time to be aware of if this is the kind of coverage you're looking for. It's also a good time to be aware of because if you're going to go non-Obamacare, you kind of want to line up your non-Obamacare start and stops with the open enrollment so that if next year you want to move, it's an easy transition. What it means for guaranteed issue on a medical insurance plan is that you have to answer health questions, okay? So the Obamacare has no health questions. You're an Affordable Care Act plan, you just sign up at the right time and you get it. It doesn't matter how sick or how healthy you are. The non-Obamacare options you can get anytime during the year, and that's because you're qualifying based on your good health. So you're gonna have to answer yes or no to a battery of questions. They're big things: cancer, heart attack, stroke, diabetes, COPD, that kind of thing. And if you can answer no to those big questions, then you can qualify at any point in the year to get one of those plans and move forward. There are two major non-Obamacare kinds of plans. One is short-term medical plans, which are major medical plans, just like an Affordable Care Act, without those extra things we were talking about, the maternity and what have you. It has a deductible and co-insurance and out-of-pocket maximum. just like you would expect. A fixed benefit medical plan is a different kind of plan. It's an indemnity plan that pays based on a fixed fee amount for all kinds of different services. So that fixed amount that's part of the policy is what it pays, whether the bills are higher or lower than that amount. So for instance, the one in the middle here that I've referenced is a $5,000 a day benefit while hospitalized on that one, okay? So, and it has all kinds of different things that it pays on: doctor visits, labs, x-rays, etc., based on a fixed fee amount. I use the daily amount of hospitalization as the most important portion of that. And sometimes when people are going to do a fixed benefit, I suggest they go to the highest level, which is what this one is, the $5,000 a day benefit. So in our area, generally, the average is about $3,000 a day for a hospitalization stay per day. So in this case, because this is a highest level benefit, if you were at a hospital that charged $3,000 a day, the benefit would pay $3,000 to the hospital and turn around and send you a check for $2,000. And that overpayment that's going to come back to you might help you to pick up on some of the other things that might be an underpayment or whatever. These are great plans. The biggest thing that they are permanent, so you can qualify for them and get them to start whenever is good for you. And then you can keep them all the way up to age 65 when you're ready for Medicare. So that's big, really big, because the short-term medical plans are just for a term. So on a fixed benefit plan, once you get it, God forbid you get sick, you can keep it and it can continue to pay. On a short-term plan, you might get sick with one of those major illnesses on the term of the plan and not be able to renew it the following year. In Illinois, we're so lucky to have only able to write short-term medical plans for 6 months. So I don't recommend my Illinois clients to do just short-term unless they know they're going to be picking up employer coverage in a couple of months or something. Then a short-term is great. It's a gap plan. But to go with just a short-term plan and not a fixed benefit as well, or which is my last column here, a combo, could be a real gotcha, because if somebody went those 6 months, got sick in those 6 months and couldn't reapply, we're outside of open enrollment and we cannot get them on an Obamacare plan, which is what they're going to need. So in Illinois, I suggest to do a combination of a fixed benefit and a short term. There are many states out there, Florida, Oklahoma, there's a bunch of them, that the states have approved 3-year short-term plans. So that becomes a totally viable option. You can buy it, for a January 1 start, and it will run for 3 years without end. And then you come up to the end of December, the 3rd year. And if something has happened, you're lined up with Obamacare, you roll back in. But those states are great. And there's also states that have 1-year plans, like Wisconsin does. And that you can do a short term, because again, you're going to line up to the open enrollment period. But in Illinois, I suggest the 3rd column here being a combination of a fixed benefit plan and a very high deductible short-term medical plan, because now you've got the best of both worlds. You have a piece of coverage that's not going to go away, and you have a stopgap on the fixed benefit plan. Okay, and what that means is that that whenever the bills get to a certain amount, the short term will take over and there's no more expense to you, and whatever fixed benefit is still paying is just going to come back to you in a form of a check. So it's a very good combination and a way to handle it. And as you can see, it's quite a bit cheaper. These numbers are for a family of 4 in Cook County, and these are 2020 plans, because at the time I made this, I didn't have the 21 costs, which are now slightly different. And you can see you can save yourself a lot of money. And on the far right, that combination plan is a lot of coverage for that money. The other thing is we in Illinois and a lot of states don't have national coverage, national PPOs. Some states only have an HMO options on exchange through Obamacare. All of the non-Obamacare plans that I'm showing here all have national PPO networks. So that's a big advantage too.
So Monica, sometimes where the ACA plan fits is where somebody does have a pre-existing condition and is below the income threshold where they're getting a subsidy. I don't know if this has changed, but I know in the past, you could have millions of dollars in assets, but not have much income and still qualify for a subsidy. Is that still true?
Yes, it is true. It's all about your taxable income. So the way that it works is for an individual, for instance, if you make less than $49,000, you start to qualify for some subsidy on a Obamacare plan. And when I say make, it's really what your modified adjusted gross income is and what you're going to file in your taxes. The way it works every year is it reconciles when you file your taxes. So it's a prepaid tax credit. So right now, when I'm helping people with their 2021 plans, my question to them is, what do you anticipate your 2021 taxable income to be? It's a little bit difficult, a little tricky, because a lot of self-employed people, and especially with COVID, people have been all over the map with what that is. But let's say I put in $45,000 as my taxable income expected, and I got $300 subsidy on my plan. If I ended up, when it trues up at the end of, when I file my taxes, if I ended up only making 40,000 instead of the 45, I would get a tax refund to make up the difference. If I put in 45, but I actually made 50, I would have to pay all that subsidy back when I filed my taxes.
And within the US, now shifting gears here a little bit, health insurance, I think during our lifetimes has been tied to a job and an employer, and that's how most people get their health insurance. Can you help us to briefly understand how group health works?
Sure. So in a group health policy, there's kind of two big buckets there too. And the big bucket is over 50 employees and under 50 employees. Under 50 is small group, over 50 is large group. Large group is going to be, swayed by the claims that are in the group. The costs are going to be influenced by the claims in the group. Under 50 is not. Under 50, traditional Affordable Care Act group is what they call age banded. So the only thing that affects the price is the zip code and the zip code that the company is in and the ages of the people. It doesn't matter if you're a man or a woman, that doesn't affect it. So that's the only thing it is. There'll be a straight banded list of what the prices are for the particular plan, and that's what it is. And most of the time, sometimes people don't know this, but on a group plan, they are the employer is required to subsidize some of the premium. And it can be anywhere from 25% of the employee only premium up to 100%. It depends on that employer and what they're going to do. There's also two ways you can go. There's traditional, like I just described, where there's no underwriting for the small group, or there's now self-insured plans for under 50. You can go down as far as 2 people now, which is crazy, but it's a great way to save money in a group that's healthy, because yeah, it's not fun to fill out a health questionnaire, but if your company has healthy people or a preponderance of healthy people, you can reduce the premiums on your group plan by sometimes as much as half of that in a traditional group. Same thing as what we just described. They're screening for healthy people. If they can, then they can put that together. And self-insured plans still follow the Affordable Care Act rules, all but for a couple of things, with some therapy requirements that are state to state, and also some infertility things that are covered state to state. That becomes up to the carrier if they're going to do that or not. And then the one thing to know is that because of what's happened in the individual market, if I look at a Blue Cross Blue Shield PPO that's exactly like the plan, the same design plan that's on Marketplace, that same plan in a group will be about 15 to 20% less. It's just what's happened in with the individual markets kind of gone nuts. And in the group markets, we do have a lot more options as far as plan designs and network sizes. So we can get the national PPOs in a group. And you can do a group as small as 2 people, and one person can even waive off, and you can still hold a group. As long as it's a corporation, a business, it can be 2 partners. It can be husband and wife partner can do that. You have to both file a K-1, but you can definitely do a small group with Blue Cross if you want to.
Well, hopefully in the future, the individual market place will have as many options as you have in the group alternative at this point. So let's look at those people age 65 and older, where they're looking at Medicare and other plan options to potentially reduce out-of-pocket costs. Can you take us through the complexity of retirement age medical health care?
Absolutely. So when you are getting close to your 65th birthday, within 3 months of your 65th birth month, because it will go effective on the 1st of the month that you turn 65. So if your birthday is March 15th, it'll go into effect on March 1st of that year. So 3 months before that, you can go out there to the website, or you can walk into a Social Security office, or you can make a phone call to Medicare and you can apply. If you know you're going to go straight to Medicare, being retired and not working anymore, then you apply for your Part A, which is hospitalization from the government, and your Part B, which is your outpatient services from the government. And Part A has no cost to you. You've paid in many years for that. Part B is subsidized to a point, but you are going to pay an amount, a premium amount for that Part B to the government. And that premium amount is going to vary based on your income. It starts at about $145, and then it goes up from there. And those two things are not those are not full coverage. I had somebody once who retired, was doing good, he was healthy, he had his Medicare A and B, he didn't understand how it worked, and God forbid, 2 or 3 years later, he had a major heart attack, went in with just A and B, and he ended up with, almost $500,000 worth of medical expense that was not covered by A and B, because it's not full coverage. Okay, so it covered some, but it didn't cover enough, and it was really devastating to him. He was able to negotiate those bills somewhat, but it really put a dent in his retirement, to say the least. So you need to have a supplement. So you want to get either a Medicare supplement or a Medigap plan, or a Medicare Advantage plan. There are 2 different kinds of supplement. In both cases, you still need your A and your B. But when you get a Medigap supplement, it's a standalone plan, and it will fill all those holes of A and B. The best plan we can do now is a Plan G, because they phased out the Plan F last year. Plan F used to cover all those holes of A and B, and now Plan G covers all the holes of A and B except for a $198 deductible for your Part B services for the year. So the only out-of-pocket you would have on a Plan G, as in George, would be $198 for the year. So it kind of helps. Good things to know about Medigap, or Medicare supplement, traditional supplement, is that there is no network. So even though you're going to be shopping from company to company to company, there's no network. So if I bought a Blue Cross or United Healthcare or an Aetna Medigap, I'm not staying within a Blue Cross, United Healthcare, or Aetna network. Any provider who accepts Medicare has to accept my supplement. So the different companies are only competing with each other for the price of the plan that they offer and their customer service. So if they have a reputable customer service, they're going to have, a good plan, and people are like them, and that helps their book of business, and the more book of business, the lower the price they can offer, etc. And the other thing to know about traditional Medigap, it doesn't include Part D drug plan, so you will have to get a standalone Part D drug plan. And again, those are going to be pieces that you add. So you're going to have 4 pieces to make your whole picture: A and B from the government, your Medigap supplement, hopefully a Plan G, and your Part D drug plan to make a full picture out of this.
And Monica, in your experience, is enrolling in that combination that you've just described, is that the best program that, or what most people end up doing that can afford, the best health insurance coverage in retirement?
It is, because we haven't gone there yet, but on a plan, a Medicare Advantage plan, those are great plans too. But the Advantage plans, you do have to stay within a network, so you don't have that wide group that you can work with. Medicare Advantage plans can be very inexpensive. Some are no premium whatsoever, that's a great advantage. But you have to stay within the network. You can end up with a lot of out of pocket or some unexpected bills if you don't do that. And they also have, even if they're zero premium, they will have out of pocket maximums on the plan. That gentleman that I just described, who had that horrible experience by not having any A and B, we actually did do a Medicare Advantage plan, because he was at the point where his income was so compromised that he needed the zero premium, and he was crossing his fingers that he wouldn't have to hit that maximum in a year. But the maximums can be more, if you're just planning, they can be more than what it would have been to buy that Plan G and Part D plans together. So you're still going to have your Part B from the government premiums you're going to have to pay, and then whatever premium on the Med Advantage. Some of them do have premiums to bring down that out of pocket. Some don't. But it's a preference for the individuals. Some people are very happy to have the ability to have the trade-off of the group of the network in order to hopefully not have to use it. But I think most of my people like the fixed idea of, this is how much I'm going to be spending for my Medicare expense. And both of these kinds of plans are going to come up every year. I didn't mention that on the Medicare Medigap supplement plan, that when you first come in, it's an important time, because the first time you come into Medicare, there is no underwriting. You can get that supplement the same price as anybody else. Okay, no health questions, no problem. But that's why you want to shop good that first time, because you're probably going to want to stay with that plan. Because if in the future you wanted to switch, you'd have to go through underwriting. So if you wanted to go from an Aetna to United Healthcare, they're going to ask health questions on the Medigap. Medicare Advantage and your Medicare Part B drug plan are both subject to the open enrollment period every year. So there's no health questions to move from Advantage to Advantage. And you can do that at the open enrollment, which is October 15th through December 7th every year. And let's see, I'm trying to think what else I haven't touched on that.
So it sounds like with an Advantage plan, if you have limited resources for healthcare, it's the best alternative for you. Or if you feel like you're going to be fairly healthy, you can get some additional benefits that you may not get in the original Medicare and supplement plans by, potentially having some dental care or maybe vision care included in a policy as well.
Yeah, so some Med Advantage plans will do that. They'll add some other benefits to it and wrap it into one piece. And of course, you can always get standalone dental vision as well if you're going to want to go with a Medigap approach. That will always be available. And now I think I forgot to mention that if somebody's working and they're going to continue working beyond age 65, And their company has more than 20 employees, so they're considered Medicare secondary. Then they don't have to take their Part B at that time. They can leave the Part B out and not pay for that until they retire. Then at the time, and there's no penalties to that because your group is becoming primary to your Part A Medicare. When you retire at age 68 or whenever it is, now you're going to sign up for your Part B. And that is still your initial enrollment period, because the Part B effective date is now what triggers, instead of age 65, Part B enrollment is your initial time. And you can get the Medigap plans with no underwriting. You can move into a drug plan with no penalties, etc.
Can you tell us a little bit about how Part D works and whether, the coverages are similar like they are in original Medicare, or, how that might work, especially if you're in need of a specific specialized medication and so forth?
Yeah. So you do need a drug plan. If you don't get a drug plan when you're first eligible, and like I said, that would be either the effective date of your Part B if you're continuing to work, or your A and B if you're 65 and just going to jump right into it. And small group people are going to, if you're in a group insurance, even if you're continuing to work and your group is less than 20, you do need to get the A and B. So most of the time it doesn't make sense to stay with the group unless your employer is paying 100% or something like that, because you are going to have to incur the B expense. And when you first are eligible, again, you can just sign up anytime during the year to get your drug plan. And you are going to want to do that, because if you don't, I often hear people say, why would I sign up? I don't take any drugs. Well, if you don't, then 3 years down the road, when you finally do need it, they're going to hit you with a penalty for not having signed up for it. And that penalty stays with the plan for your lifetime. So it's not worth it. Go out, get the cheapest one out there. This year, 2021, we actually have one in Illinois that's only $7.30 a month. So that's your placeholder, get it. And of course it would work for, the one-offs. If you don't take any drugs, but you got a sinus infection, it's still going to work for that antibiotic or whatever you're going to get. So you want to have it. And the list, again, these are sold by private insurance companies, but just like Medigap, like a Plan G is a Plan G is a Plan G, it doesn't matter what company sells you, all the details are the same. That is the same with the Medicare Part D. All the drug list, what's considered the covered drug list by Medicare, is the same drug list that all of the plans have to cover. But where they do vary, and why you should shop it every year, is what your drugs are, because one plan might cut a new deal with a different pharmacy, or might cut a new deal with a different drug manufacturer. So what you do in the bottom bullet point there is really great. You go to medicare.gov, and there's a button to click on, shop my drug plan. You go in there. It's very easy to use. You drop in your particular drugs and the dosages of those drugs, and put in your favorite pharmacy to go to, or if it's mail order, you put that in, and it will rifle through all the plans that are on there and make a suggestion of what's going to be the best plan for you, the least expensive cost of the drugs for you, and the least expensive cost of the premium, and give you a good source. You'll also notice when you go on there, they put stars next to those, you probably want to consider that too, because sometimes if a drug plan is brand new to it might not have any stars. It's too new to be evaluated, and that you don't want to be a guinea pig. It's not worth it. A few bucks here or there, you might want to but you never know. I mean, some people don't care, But anyway, yeah, that's pretty much the ins and outs of the drug plan. You kind of want
Well, Monica, that's really helpful, because I think, just your recommendation for people to, go to medicare.gov every year and, list the prescriptions that they're using and see if there's a a plan that makes sense for them, to save a little bit of money for the coming year. That's a good recommendation. And also too, to even if you don't think you're going to need this, just to do something really inexpensive, where I know we've had this conversation before, like even your dad just spending $7 a month just to make sure he's got the coverage so he can avoid future penalties.
Right.
So that wraps up our discussion on Medicare options. And we have a few planning items in healthcare to cover, and I'll go ahead and switch to those slides here. So the first thing I'd like to cover is healthcare savings accounts. And healthcare savings accounts are really great because the government has created a vehicle where any contributions you put in there are tax-free, just like, or tax deductible, I mean, just like your 401k plan. All the earnings grow tax-free. So there's never going to be a federal tax and just state taxes in a couple of different states. And then when you make withdrawals, they have to be specifically for eligible healthcare expenses. But the great thing about these is once you set up these plans, you can go back and reimburse yourself and backdate up until the date that you set up these HSAs. And HSAs were set up a number of years ago. So as long as you're in one of these HSA compatible plans, which are high deductible plans, you should be eligible for it. And you can see what the contribution limits are for these. And we would encourage everybody to really consider having one of these, because you're going to have healthcare expenses in retirement, and to do this while you're working really makes a lot of sense. So people often ask us, what should I allocate for my healthcare expenses in retirement? And we've got some numbers for you to just chew on here a little bit. In 2020, Fidelity estimates that a retiring couple age 65 will spend almost $300,000 in healthcare for the rest of their lives. And then if you're a single man, it's $140,000, and a woman, $155,000. Vanguard says that the median annual healthcare cost for a 65-year-old woman is $5,200. And if you look at inflation, inflation makes just about everything that we do more expensive year by year. And then when you look into the future, really some of those numbers are very compelling. So $5,200 at a 6.5% inflation rate in 20 years is over $18,000. So factoring in your healthcare expenses into what you do for your retirement budget is really important. And we recommend that people do that every year, and revisit that annually. And the last part, as Monica talked about Medicare, for Parts B, which is your outpatient doctor visits, and Part D, which is the drug prescriptions, those are income-based numbers. So the premium dollars that you're going to pay are based on your modified adjusted income. And if you're over $87,000 as an individual, or over $174,000 for a married couple, you could have a surcharge. It's called the IRMA. It's a progressive tax. And a lot of times your premium could be more than double what you're paying. So, at the bottom, you would be at $1,735 a month. And if you're at the top tax bracket, it could cost you $6,800 a month. So there are some ways that you can reduce your MAGI, and we've listed 6 of them here. You can put more money into your 401k. You can fund an HSA plan. If you're in a situation where you're over age 72 and you're taking money from your IRA, if you make charitable contributions directly from your IRA, that can help. If you have a life event that creates a significant income differentiation, whether it's a marriage or a divorce or death of a spouse or what have you, that can make a difference, and you can actually file for something like that. Or converting your IRA, a traditional IRA, to a Roth And then finally, if you have business expenses, if you're a business owner and you can accelerate some of those expenses into the current year, that can offset some of your income as well. What we do is we offer to our clients, and quite frankly, anybody who really would need this, the opportunity to do some tax return modeling where we can do different what if scenarios and look at some of the ways that we could reduce your Maggie to reduce these insurance premiums, which can really hurt over time. Monica, I wanted you to maybe just comment a little bit, if you could, on the Supreme Court case on Obamacare and what some of those issues are at this point, and what's kind of likely going forward. And I know that that's kind of a hot topic these days.
Yeah, I have people that are nearing retirement, and they'll call me up and they'll say, "So give me an idea what my healthcare costs will be, when I'm, 5 years from now, because they're going to retire early." And it's changed so much over the years. It's really hard to say. But with the Supreme Court, is the idea there is that when the 2018 tax reform came out, part of that tax reform bill that was passed was to get rid of the individual mandate. And what that is, and it was heavy. If you didn't buy an Obamacare plan, you were not allowed, you would, if you got anything but an Obamacare plan, you would be penalized. And you could pay anywhere from, as low as just a few $100s if you're just a little bit above that threshold, to thousands of dollars if you didn't get that Obamacare plan. So when 2018, the end of the year, they threw that out, there's no more penalty. That was a non-issue anymore. Then the courts brought that should make the whole thing illegal, that holds that the law is written in such a way that that's the thread that pulls, that unravels the whole thing. And this has been out there for years. This has been a couple of years this has been going on. So it's just now making its way to the Supreme Court. Even if that happens, nothing's going to change this year, 2021. Those plans are already set. Even when they wrote and passed the Affordable Care Act, it took 3 years for that to go into effect. So this stuff moves very slowly. It's not just going to drop. You're not going to get dropped somewhere mid-year or something like that. They'd have to write new law and then, wait possibly until 2022 at the earliest to make something change. So keep an eye on it. We'll see.
And at this point, too, it looks highly unlikely that any pre-existing conditions are going to be thrown to the wayside. According to legal scholars, it's unlikely that this ACA is going to be totally overturned, at least from things that I've read. Monica, I just want to thank you again for your time today and being our guest on Ask the Expert in Healthcare Insurance, and we appreciate all the knowledge and ideas that you shared with the audience. As we look at our Q&A, I know that we've taken a lot of your time today, so we would want to be sensitive to that. And Dale, maybe we can just answer 2 or 3 questions that the audience might have.
Sure. And as I said at the beginning, we will publish any other questions in an FAQ document within a few days. So let me just give you a couple that have been submitted. One is, the question is, what is the trade-off between the timing of delaying a payment of medical bills and risk to my credit rating? So in other words, if I don't pay my bill the very first time I get it from the hospital, what are the potential impacts to my credit rating?
Well, everybody kind of knows that the medical billing thing is just a mess. So it's not, there are some providers who won't even send you out a bill until they get the processed insurance. I love those guys. And there's others that will just start peppering you with bills with nothing done, nothing, and they'll start the clock rolling right away. you need just to be aware of that 90-day. That's usually when they're going to start getting nasty. And so at that point, you would want to call them and tell them to give you another 90 days, and they will do it. And if you want to shop for providers with better billing services, that might be a good idea too. But when you need that extra time, I mean, I've seen claims go on for like, I think the longest I remember is about 18 months that they were still being messed up. And we had to just keep working it and keep pushing it back and keep working it and keep pushing it back. That was a gentleman who had gotten a pre-authorization for his back surgery from his doctor. The doctor said he had the pre-auth. They went ahead and did the back surgery, and the insurance company denied it, saying there was no pre-authorization and they didn't follow the protocol that you're supposed to before that. And we had to work it for a year and a half before we got that cleaned up, but the insurance company did cover it. They did find the pre-auth. They did assume there was some problems with the pre-authorization, but they let it go and they covered it. So.
And Monica, part of some of what I've heard over time too is that whether it's your doctor's office or the hospital, as long as they're in control of that billing and communication with you, you don't have to worry about your credit being hurt. It's when they turn that over to credit agency that becomes an issue. And in a lot of cases, I think you've mentioned this to me in the past, you can call and negotiate your bill, and a lot of times they'll give you time to pay them monthly over some extended period of time with 0% interest, or if you offer to pay a lump sum, they'll reduce that. Can you maybe just comment on that a little bit?
Yeah, absolutely. I mean, it's a business. Healthcare is screwy as heck. It's not like any other business, where you're trading this widget for this amount of money and that's it, right? The transaction is odd. So you need to be your own best advocate. I've seen people negotiate. I had one crafty client who I was kind of telling him to negotiate with the out-of-pocket that he had once his insurance had covered it. And he called up and he actually talked to somebody in the billing who handed him off to a supervisor who had enough clout to make a call like this. And he said, listen, I have $2,100, I owe you $6,000. I have $2,100 in my HSA. If I come over there today and pay it, will we call it clean? And they took it. So
that's great.
Yeah.
That's great.
Yeah, it's haggling.
Gail, do we have any other questions?
Yeah, let's do one more and then we probably need to wrap it up. This person says, I currently have a group plan and turned 65 recently. My spouse is younger and we have a college-age child. So do I need to do anything about applying for Medicare if I don't intend to use it right away?
Yeah, that is the case. If that group is over 20 employees, then he could certainly just only get the Part A. That would allow him to keep his group plan and allow his spouse and his child to still be on that group plan. He of course could, if it makes more sense financially, to come out of that. That would be a qualifying event for his spouse and his child to get an individual plan through Marketplace or otherwise, and then that would also allow him to go straight to Medicare. So you kind of put the numbers side by side and see what makes most amount of sense for them. Yeah.
Great. Well, I think that's about all the time we have. So I'd like to thank Mike and Monica for presenting and thank all of you for listening. As I said, we will send out a copy of the slides and an FAQ document. And also you can feel free to reach out to us if you have more detailed questions or very specific questions. So with that, we'll release you all to your day and we thank you again.
Bye now.